Fluid surrounds all the cells in the body and is also inside cells. Body fluids contain electrolytes such as sodium and potassium. They also have a certain degree of acidity. Fluid, electrolyte, and acid-base balances within the body maintain the health and function of all body systems. In this chapter, you will learn how the body normally maintains fluid, electrolyte, and acid-base balance. You'll also learn how imbalances develop, how various fluid, electrolyte, and acid-base imbalances affect patients, and ways to help patients maintain or restore balance safely. The characteristics of body fluids influence body system function through their effects on cell function. All of these characteristics have regulatory mechanisms which keep them in balance for normal function. Body fluids containing water, sodium, and other electrolytes are distributed between distinct compartments: extracellular fluid, outside the cells, and intracellular fluid, inside the cells. Extracellular fluids. Interstitial fluids are the fluids between cells and outside the blood vessels. These include lymph, the fluid in the lymphatic vessels. Intravascular fluid is blood plasma found in the vascular system. And transcellular fluids are secreted by epithelial cells and include cerebrospinal fluid, pleural, peritoneal, and synovial fluids. This picture is from page 883 in your text, and you might take a look to make sure that you understand that. Can you name some cations? What about some anions? Cations include sodium, potassium, calcium, and magnesium. Anions are chloride, bicarb, and sulfate. Anions and cations combine and make salt. If you put table salt, NaCl, in water, it separates into sodium and chloride. Fluid that contains a large number of dissolved particles is more concentrated than the same amount of fluid that contains only a few particles. Osmolality of a fluid is a measure of the number of particles per kilogram of water. Electrolytes, the solutes, are dissolved in plasma, the solution. The liquid in which a solute is dissolved is called a solvent. There are lab values on page 883 that are normal adult values that you will want to learn. Solutions are classified as hypertonic, isotonic, or hypotonic. Particles that cannot pass across cell membranes easily determine the tonicity of a fluid. A fluid with the same concentration of non-permeant particles as normal blood is called isotonic. Isotonic solutions have the same osmolarity as blood, similar to normal saline or 0.9% sodium chloride. A hypotonic solution is more dilute than blood, and a hypertonic solution is more concentrated than normal blood. A hypertonic solution, such as 3% sodium chloride, pulls fluid from cells, causing them to shrink. A hypotonic solution, such as 0.45% sodium chloride, moves fluids into cells, causing them to enlarge. Some particles, such as urea, pass easily through cell membranes. Others, such as sodium, cannot cross so easily. Active transport requires energy in the form of ATP to move electrolytes across cell membranes against the concentration gradient, from areas of lower concentration to areas of higher concentration. It is enhanced by carrier molecules within a cell that bind themselves to incoming molecules. One example of active transport is the sodium-potassium pump, which moves sodium out of a cell and potassium into it, keeping ICF lower in sodium and higher in potassium than ECF. Diffusion is affected by molecular size, concentration, and temperature of a solution. The difference between two concentrations is known as the concentration gradient. Diffusion is passive movement of electrolytes or other particles down the concentration gradient. from areas of higher concentration to lower concentrations. Within a body compartment, electrolytes diffuse easily by random movements until the concentration is the same in all areas. Fluids and electrolytes shift from compartment to compartment, and compartments are separated by cell walls and capillary membranes. Osmosis attempts to equalize concentrations of molecules on both sides of the membrane. Osmotic pressure is the drawing power of water and depends on the number of molecules in the solution. Hydrostatic pressure is the force of the fluid pressing outward against the surface. In the process of filtration, hydrostatic pressure differences determine the movement of water. With increased hydrostatic pressure on the venous side of the capillary bed, edema will occur. However, diffusion of electrolytes across cell membranes requires proteins that serve as ion channels. For example, when a sodium channel in a cell membrane is open, sodium diffuses passively across the cell membrane into the intracellular fluid because the concentration is lower in the intracellular fluid. Opening of ion channels is tightly controlled and plays an important part in muscle and nerve function. All of this should be reviewed for you from your anatomy and physiology class as well as your pathophysiology class. Osmosis moves water through a semi-permeable membrane. Water moves across cell membranes by osmosis, a process by which water moves through a membrane that separates fluids with different particle concentrations. Cell membranes are semi-permeable, which means that water crosses them easily, but they are not freely permeable to many of the types of particles, including electrolytes such as sodium and potassium. These semi-permeable cell membranes separate interstitial fluid from intracellular fluid. The fluid in each of these compartments exerts osmotic pressure, an inward pulling force causing particles in the fluid. Particles already inside the cell exert ICF, osmotic pressure, which tends to pull water into the cell. Particles in the interstitial fluid exert interstitial fluid osmotic pressure, which tends to pull water out of the cell. Water moves into the compartment that has a higher osmotic pressure or inward pulling force until the particle concentration is equal in the two compartments. If the particle concentration in the interstitial compartment changes, osmosis occurs rapidly and moves water into or out of the cells to equalize osmotic pressure. For example, when a hypotonic solution, more dilute than normal body fluids, is administered intravenously, it dilutes the interstitial fluid, decreasing its osmotic pressure to below intracellular osmotic pressure. Water moves rapidly into cells until the two osmotic pressures are equal again. On the other hand, infusion of a hypertonic IV solution causes water to leave the cells by osmosis to equalize the osmolality between interstitial and intracellular compartments. Capillary filtration moves fluid between vascular and interstitial compartments. Fluid moves into and out of capillaries between vascular and interstitial compartments by the process of filtration. Filtration is the net effect of four forces: two that tend to move fluid out of capillaries and small venules, and two that tend to move fluid back into them. Hydrostatic pressure is the force of the fluid pressing outward against the surface. Similarly, capillary hydrostatic pressure is a relatively strong outward pushing force that helps move fluid from capillaries into the interstitial area. Interstitial fluid hydrostatic pressure is a weaker opposing force that tends to push fluid back into capillaries. Blood contains albumin and other proteins known as colloids. Colloid proteins of blood are much larger than electrolytes, glucose, and other molecules that dissolve easily. Most colloids are too large to leave capillaries in the fluid that is filtered, so they remain in the blood. Because they are particles, colloids exert osmotic pressure. Blood colloid osmotic pressure, also called oncotic pressure, is an inward pulling force caused by blood proteins that help move fluid from the interstitial area back into the capillaries. Interstitial fluid, colloid osmotic pressure, normally is a very small opposing force. At the arterial end of a normal capillary, capillary hydrostatic pressure is strongest and fluid moves from the capillary into the interstitial area, bringing nutrients to cells. At the venous end, capillary hydrostatic pressure is weaker and the colloid osmotic pressure of the blood is stronger. Thus, fluid moves into the capillary at the venous end, removing waste products from cellular metabolism. Lymph vessels remove any extra fluid and proteins that have leaked into the interstitial fluid. Disease processes and other factors that alter these forces may cause accumulation of excess fluid in the interstitial space, known as edema. Inflammation is another cause of edema. It increases capillary blood flow and allows capillaries to leak colloids into interstitial space. The resulting increased capillary hydrostatic pressure and increased interstitial colloid osmotic pressure produce localized edema in the inflamed tissues. Fluid homeostasis is the dynamic interplay of three processes: fluid intake and absorption, fluid distribution, and fluid output. Human total daily fluid output consists of hypotonic sodium-containing fluids. People must have intake of an equivalent amount of hypotonic sodium-containing fluid or water plus foods with some salt to maintain fluid balance. Fluid intake occurs orally through drinking, but also through eating because most foods contain some water. Food metabolism creates additional water. Average fluid intake from these routes for healthy adults is about 2,300 mils, although it varies widely. Other routes of fluid intake include IV, rectal, such as enemas, and irrigation of body cavities that can absorb fluid. Although you might think the major regulator of oral fluid intake is thirst, habit and social reasons actually account for most fluid intake. Thirst, the conscious desire for water, is an important regulator of fluid intake when plasma osmolality increases or blood volume decreases. Fluid distribution between extracellular and intracellular compartments occurs by osmosis. Fluid distribution between blood vessels and interstitial portions of the extracellular fluid occurs by filtration. This diagram shows stimuli that affect the thirst mechanism. The thirst control mechanism is located within the hypothalamus in the brain. Osmoreceptors continually monitor plasma osmolality. When it increases, they cause thirst by stimulating neurons in the hypothalamus. Dry oral mucous membranes also cause thirst. People who are alert can obtain fluid or communicate their thirst to others, and fluid intake restores fluid balance. Infants, patients with neurological or psychological problems, and some older adults who are unable to perceive or communicate their thirst or are at risk for dehydration. Insensible water loss through the skin and lungs is continuous. It increases when a person has a fever or a recent burn to the skin. Sweat, which is visible and contains sodium, occurs intermittently and increases fluid output substantially. The GI tract plays a vital role in fluid balance. Approximately 3 to 6 liters of fluid moves into the GI tract daily and then returns again to the extracellular fluid. The average adult normally excretes only 100 mils of fluid each day through feces. However, diarrhea causes a large fluid output from the GI tract. The kidneys are the major regulators of fluid output because they respond to hormones that influence urine production. When healthy adults drink more water, they increase urine production to maintain fluid balance. If they drink less water, sweat a lot, or lose fluid by vomiting, their urine volume decreases to maintain fluid balance. These adjustments are primarily caused by the actions of antidiuretic hormone and the renin-angiotensin-aldosterone system and atrial natriuretic peptides ADH regulates the osmolality of ADH regulates the osmolality of body fluids by influencing how much water is excreted in urine. The RAAS regulates extracellular fluid volume by influencing how much sodium and water is excreted in the urine. ANP also regulates extracellular fluid volume by influencing how much sodium and water is excreted in urine. Major hormones that influence renal fluid excretion include antidiuretic hormone, aldosterone, and AMP. ADH is synthesized by neurons in the hypothalamus that release it from the posterior pituitary gland. ADH circulates in the blood to the kidneys where it acts on the collecting ducts. Its name, antidiuretic hormone, tells you what it does. It causes renal cells to reabsorb water, taking water from the renal tubular fluid and putting it back into the blood. This action decreases urine volume, concentrating the urine while diluting the blood by adding water to it. People normally have some ADH released to maintain fluid balance. More ADH is released if body fluids become more concentrated. Factors that increase ADH levels include severely decreased blood volume, as in dehydration or hemorrhage, pain, stressors, and some medications. ADH levels decrease if body fluids become too dilute. This allows more water to be excreted in urine, creating a larger volume of dilute urine and concentrating the body fluids back to normal osmolality. For example, ethyl alcohol decreases ADH release, which causes people to urinate frequently when they drink alcoholic beverages. The renin-angiotensin-aldosterone system regulates extracellular fluid volume by influencing how much sodium and water is excreted in the urine. It also contributes to regulation of blood pressure. Specialized cells in the kidneys release the enzyme renin, which acts on angiotensin, an inactive protein secreted by the liver that circulates in the blood. Renin converts angiotensin to angiotensin 1, which other enzymes in the lung capillaries convert to angiotensin 2. Angiotensin 2 has several functions, one of which is vasoconstriction in some vascular beds. Important fluid homeostasis functions of angiotensin 2 include stimulation of aldosterone release from the adrenal cortex. This slide summarizes the components of fluid balance. Okay, a patient is diaphoretic and has an oral temperature of 104. These are classic signs of what? ADH deficit, extracellular fluid loss, insensible water loss, or sensible water loss? What do you think? The answer is D, sensible water loss. If disease processes, medications, or other factors disrupt fluid intake or output, imbalances sometimes occur. For example, with diarrhea, fluid output is increased, and a fluid imbalance or dehydration occurs if fluid intake does not increase appropriately. Two major types of fluid imbalances are known as volume imbalances and osmolality imbalances. Volume imbalances are disturbances in the amount of fluid in the extracellular compartment. Osmolality imbalances are disturbance in the concentration of body fluid. Volume and osmolality imbalances may occur separately or in combination. With an extracellular fluid volume imbalance, too little or too much isotonic fluid is present. ECV deficit and excess are abnormal volumes of isotonic fluid manifested as sudden changes in body weight and changes in markers of vascular and interstitial volume. Extracellular volume deficit is present when isotonic fluid is insufficient in the extracellular compartment. Remember that a lot of sodium is found in normal extracellular fluid. With extracellular fluid deficit, output of isotonic fluid exceeds intake of sodium-containing fluid. Because extracellular fluid is both vascular and interstitial, signs and symptoms arise from lack of volume in both of these compartments. Extracellular volume excess occurs when too much isotonic fluid is found in the extracellular compartment. Intake of sodium-containing isotonic fluid has exceeded fluid output. For example, when you eat more salty food than usual and drink water, you may notice that your ankles swell or your rings on your fingers fit tightly, and you gain 2 pounds or more overnight. These are manifestations of mild extracellular fluid volume excess. In an osmolality imbalance, body fluids become hypertonic or hypotonic, and this causes osmotic shifts of water across cell membranes. Osmolality imbalances are called hypernatremia or hyponatremia. Osmolality imbalances are concentrations of body fluids that are abnormal, manifested as altered serum levels and decreased level of consciousness. Hypernatremia, also called water deficit, is a hypertonic condition. One of 2 general causes make body fluids too concentrated: loss of relatively more water than salt, or gain of relatively more salt than water. When the interstitial fluid becomes hypertonic, water leaves the cells by osmosis and they shrivel. Signs and symptoms of hypernatremia are those of cerebral dysfunction, which arise when brain cells shrivel. Nobody needs their brain cells shriveling, right? Hyponatremia, also called water excess or water intoxication, is a hypotonic condition. It arises from gain of relatively more water than salt or loss of relatively more salt than water. The excessively dilute condition of interstitial fluid causes water to enter cells by osmosis, causing cells to swell. Signs and symptoms of cerebral dysfunction occur when brain cells swell. The extracellular volume deficit and hypernatremia often occur at the same time. This combination is called clinical dehydration. The extracellular volume is too low and the body fluids are too concentrated. Clinical dehydration is common with gastroenteritis or other causes of severe vomiting and diarrhea when people are not able to replace their fluid output with enough intake of dilute sodium-containing fluids. Signs and symptoms of clinical dehydration are those of both extracellular volume deficit and hypernatremia. Treatment for extracellular volume excess consists of sodium restriction and fluid restriction. If it's severe, treatment for hyponatremia usually involves water restriction. On this slide, you want to review each imbalance and its parallel in health and disease. You can best understand electrolyte balance by considering 3 processes involved in electrolyte homeostasis: electrolyte intake and absorption, electrolyte distribution, and electrolyte output. Interplay of electrolyte intake and absorption, electrolyte distribution, and electrolyte output determines the balance of potassium, calcium, magnesium, and phosphate. Intake comes from foods and beverages. Some substances enhance or hinder electrolyte absorption. Although sodium is an electrolyte, it is not included here because serum sodium imbalances are the osmolality imbalances discussed previously. Electrolyte distribution is an important issue. Note that the electrolyte values that you review from lab reports are measured in blood serum and do not measure intracellular levels. Electrolyte output occurs through normal excretion in urine, feces, and sweat. Output also occurs through vomiting, drainage tubes, and fistulas. When electrolyte output increases, electrolyte intake must increase in order to maintain balance. Similarly, if electrolyte output decreases, as with oliguria, electrolyte intake must also decrease in order to maintain balance. There is a table on page 889, table 41-4, where you want to look at electrolyte intake and absorption, distribution, and output. Factors such as diarrhea, endocrine disorders, and medications that disrupt electrolyte homeostasis cause electrolyte imbalances. Hypokalemia is abnormally low potassium concentration in the blood. Hypokalemia results from decreased potassium intake and absorption, a shift in potassium from the ECS into the cells, and an increased potassium output. Common causes of hypokalemia from increased potassium output include diarrhea, repeated vomiting, and use of potassium-wasting diuretics. People who have these conditions need to increase their potassium intake to reduce their risk of hypokalemia. Hypokalemia causes muscle weakness, which becomes life-threatening if it includes respiratory muscles, and potentially life-threatening cardiac dysrhythmias. Hyperkalemia is abnormally high potassium ion concentration in the blood. In general, causes are increased potassium intake and absorption, shift of potassium from the cells into the ECS, and decreased potassium output. People who have oliguria or decreased urine output are at high risk of hyperkalemia and the resultant decreased potassium output unless their potassium intake also decreases substantially. Understanding this principle helps you remember to check urine output before you administer IV solutions containing potassium. Hyperkalemia can cause muscle weakness and potentially life-threatening cardiac dysrhythmias and cardiac arrest. Hypocalcemia is abnormally low calcium concentration in the blood. The physiologically active form of calcium in the blood is ionized calcium. Total blood calcium also contains inactive forms that are bound to plasma proteins and small anions such as citrate. Factors that cause too much ionized calcium to shift to bound forms cause symptomatic ionized hypocalcemia. People who have acute pancreatitis frequently develop hypocalcemia because calcium binds to undigested fat in their feces and is excreted. This process decreases absorption of dietary calcium and increases calcium output by preventing resorption of calcium contained in the GI fluid. Hypocalcemia increases neuromuscular excitability, which is the basis for its signs and symptoms. Hypercalcemia is abnormally high calcium concentration in the blood. Hypercalcemia results from increased calcium intake and absorption, a shift from the bones to the ECS, or decreased calcium output. Patients with cancer often develop hypercalcemia because some cancer cells secrete chemicals into the blood that are related to parathyroid hormone. When these chemicals reach the bones, they cause a shift of the calcium from the bones into the ECS. This weakens the bones, and the person sometimes develops pathological fractures, or bone breakage caused by forces that would not break a healthy bone. Hypercalcemia decreases neuromuscular excitability, the basis for its other signs and symptoms, which the most common of is lethargy. Hypomagnesemia is abnormally low magnesium concentration in the blood. Its general causes include decreased intake and absorption, a shift from the plasma to its inactive bound form, or increased magnesium output. Signs and symptoms are similar to those of hypocalcemia because it also increases neuromuscular excitability. Hypermagnesemia is abnormally high magnesium concentration in the blood. End-stage renal disease causes this unless the person decreases the amount of magnesium intake to match the decreased output. Signs and symptoms caused by decreased neuromuscular excitability, like lethargy, and decreased deep tendon reflexes, which are the two most common. For optimal cell function, the body maintains a balance between acids and bases. Acid-base homeostasis is the interplay of three processes: acid production, acid buffering, and acid secretion. Normal acid-base balance is maintained with acid excretion equal to acid production. The more hydrogen ions that are present, the more acidic the solution is. The degree of acidity in blood and other body fluids is reported from the clinical lab as pH. If pH goes outside the normal range, enzymes within the cells don't function properly. Hemoglobin doesn't manage oxygen properly, and serious physiological problems, including death, can occur. Lab tests of a sample of arterial blood, called ABGs, or arterial blood gases, are used to monitor a patient's acid-base balance. And you can review the table of ABGs on page 892, and I encourage you to do that. Cellular metabolism constantly creates two types of acids, carbonic acid and metabolic acid. Cells produce carbon dioxide, or CO2, which acts as an acid in the body by converting it to carbonic acid. Metabolic acids are any acids that are not carbonic acid. They include citric acid, lactic acid, and many others. If too many free hydrogen ions are present, a buffer takes them up, so they are no longer free. If too few are present, a buffer can release hydrogen ions to prevent an acid-base imbalance. Buffers work rapidly, within seconds. All body fluids contain buffers. The major buffer in ECS is the bicarbonate buffer system, or HCO3, which buffers metabolic acids. It consists of a lot of bicarbonate and a small amount of carbonic acid, normally a 20-to-1 ratio. Addition of hydrogen ions released by a metabolic acid to a bicarb ion makes more carbonic acid. Now the hydrogen is no longer free and will not decrease the blood pH. If too few hydrogen ions are present, the carbonic acid portion of the buffer pair will release some, increasing the bicarb, again returning pH to normal. Other buffers include hemoglobin, protein buffers, and phosphate buffers. Cellular and bone buffers also contribute. Buffers normally keep the blood from becoming too acid when acids that are produced by the cells circulate to the lungs and kidneys for excretion. The body has two acid excretion systems, lungs and kidneys. The lungs excrete carbonic acid and the kidneys excrete metabolic acid. When you exhale, you excrete carbonic acid in the form of CO2 and water. If the PaCO2, or the level of carbon dioxide in the blood, rises, the chemoreceptors trigger faster and deeper respirations to excrete the excess. If the PaCO2 falls, the chemoreceptors trigger slower and shallower respirations, so more of the CO2 produced by the cells remains in the blood and makes up the deficit. These alterations in respiratory rate and depth maintain the carbonic acid portion of acid-base balance. Sometimes people who have lung disease have difficulty with normal excretion of carbonic acid. This causes it to accumulate and makes the blood more acid. The kidneys excrete all acids except carbonic acid. They secrete hydrogen ions into the renal tubular fluid, putting bicarb back into the bloodstream at the same time. If too many hydrogen ions are present in the blood, renal cells move more hydrogen into the renal tubules for excretion, retaining more bicarb in the process. If too few hydrogen ions are present in the blood, renal cells secrete fewer. Phosphate buffers in the renal tubular fluid keep the urine from becoming too acidic when the kidneys excrete hydrogen ions. If the kidneys need to excrete a lot of hydrogen, renal tubular cells secrete ammonia, which combines with the hydrogen ions in the tubules to make NH4, or ammonium ions. Buffering by phosphate and the creation of NH4 turn free hydrogen into other molecules in the renal tubular fluid. This enables metabolic acid excretion in the urine without making urine too acidic. People who have kidney disease often have difficulty with normal excretion of metabolic acids. People develop acid-base imbalances when their normal homeostatic mechanisms are dysfunctional or overwhelmed. The term acidosis describes a condition that tends to make the blood relatively too acidic. Because our cells produce two types of acid, two different types of acidosis have been identified: respiratory acidosis and metabolic acidosis. The term alkalosis describes a condition that tends to make the blood relatively too basic or alkaline. Two types of alkalosis are known: respiratory alkalosis and metabolic alkalosis. The body has compensatory mechanisms that limit the extent of pH change with acid-base imbalances. It's important to remember that the kidney or lung cannot compensate for itself. Therefore, the kidneys compensate for respiratory acid-base imbalances, and the respiratory system compensates for metabolic acid-base imbalances. These compensatory mechanisms don't correct the problem, but they assist the body to adapt. However, if the underlying condition is not corrected, these compensatory mechanisms will fail. It is important that you review the table on page 894 about acid-base imbalances. Respiratory acidosis arises from alveolar hypoventilation. The lungs are unable to excrete enough carbon dioxide, so the PaCO2 rises, creating an excess of carbonic acid in the blood, which decreases the pH. The kidneys compensate by increasing excretion of metabolic acids in the urine, which increases blood bicarb. This compensatory process is slow, often taking 24 hours to show clinical effect and 3 to 5 days to reach steady state. Decreased cerebrospinal fluid pH and intracellular pH of brain cells causes decreased levels of consciousness. Respiratory alkalosis arises from alveolar hyperventilation. The lungs excrete too much CO2 and water. The PaCO2 falls, creating a deficit of carbonic acid in the blood, which increases the pH. Respiratory alkalosis is usually short-lived, thus the kidneys do not have time to compensate. When the pH of the blood, cerebrospinal fluid, and intracellular fluid increase acutely, cell membrane excitability also increases, giving rise to neurological symptoms such as excitement, confusion, and paresthesia. If the pH rises enough, the central nervous system depression if the pH rises enough, central nervous system depression can occur. Metabolic acidosis occurs from an increase in metabolic acid or a decrease in base or bicarbonate. The kidneys are unable to excrete enough metabolic acids which accumulate in the blood, or bicarb is removed from the body directly as with diarrhea. In either case, the blood bicarb decreases and the pH falls. With an increase in metabolic acids, blood bicarb decreases because it is used to buffer metabolic acids. Similarly, when patients have conditions that cause the removal of bicarb, the amount of bicarb in the blood decreases. To help identify the specific cause, healthcare providers and the lab calculate the anion gap, a reflection of unmeasured anions in the plasma. You calculate anion gap by subtracting the sum of plasma concentrations of chloride and bicarb from the plasma concentration of sodium. When reviewing lab reports, check the reference values from the lab that measured the electrolyte concentrations. The abnormally low pH and metabolic acidosis stimulates chemoreceptors, so the respiratory system compensates for the acidosis by hyperventilation. Compensatory hyperventilation begins in a few minutes and removes carbonic acid from the body. This process does not correct the problem, but it helps limit the pH decrease. Metabolic acidosis decreases one's level of consciousness. Metabolic alkalosis occurs from a direct increase in base, or a decrease in the metabolic acid, which increases blood bicarb by releasing it from its buffering function. Common causes include vomiting and gastric suction. The respiratory compensation for metabolic alkalosis is hypoventilation. The decreased rate and depth of respiration allow carbonic acid to increase in the blood, as can be seen in an increased PaCO2. The need for oxygen may limit the decrease in respiratory compensation for metabolic alkalosis. Because bicarb crosses the blood-brain barrier with difficulty, neurological signs and symptoms are less severe or even absent with metabolic alkalosis. Recall that the kidney or lung cannot compensate for itself. Therefore, the kidneys compensate for respiratory acid-base imbalances, and the respiratory system compensates for metabolic acid-base imbalances. Acid-base imbalances are caused by excesses or deficits of carbonic or metabolic acids, manifested as changes in level of consciousness and abnormalities in PaCO2, HCO3, and pH. You will apply knowledge about fluid, electrolyte, and acid-base imbalance in many clinical settings. You will incorporate nursing and collaborative interventions to maintain or restore fluid and electrolyte balance. Skills and techniques for safe IV therapy are vital to the nursing knowledge base and the focus of much nursing research to support evidence-based practice. Using a systematic approach in assessment enables you to help patients safely maintain or restore fluid, electrolyte, and acid-base balances. A patient's fluid, electrolyte, or acid-base imbalance is sometimes so severe that it prevents initial discussion of his or her expressed needs, values, or preferences. However, when a patient is alert enough to discuss care, you need to elicit this information. Focus on the patient's experience with fluid, electrolyte, or acid-base alterations and his or her perceptions of the illness. Ask about the patient's greatest concerns regarding their fluid status to build a basis for an active partnership in planning, implementing, and evaluating patient-centered care. Clinical assessment begins with the patient history designed to reveal risk factors that cause or contribute to fluid, electrolyte, and acid-base imbalances. Ask specific, focused questions to identify factors that contribute to a patient's potential imbalances. First, assess a patient's age. Infants are at greater risk for extracellular fluid volume deficit and hypernatremia because body water loss is proportionately greater per kilogram of weight. Fluctuations in fluid balance are greater in adolescent girls because of hormonal changes associated with the menstrual cycle. Older adults experience a number of age-related changes that potentially affect fluid, electrolyte, and acid-base balances. They often have more difficulty recovering from imbalances resulting from the combined effects of normal aging, various disease conditions, and multiple medications. Excessive sweating without replacement of salt and water can lead to extracellular volume deficit, hypernatremia, or clinical dehydration. Ask patients about their normal level of physical work and whether they engage in vigorous exercise in hot environments. Do these patients have fluid replacements containing salt available during exercise and activity? Assess their dietary intake of fluids, salt, foods rich in potassium, calcium, and magnesium. Ask patients if they follow weight loss diets. Starvation diets and those with high fat and no carb content often lead to metabolic acidosis. In addition, assess the patient's ability to chew and swallow, which, if altered, interferes with adequate intake of electrolyte-rich foods and fluids. Take an alcohol intake history. Chronic alcohol abuse commonly causes hypomagnesemia, in part because it increases renal magnesium excretion. And you want to obtain a complete list of your patient's current medications, including over-the-counter medications and herbal preparations. This will allow you to assess for risks of fluid, electrolyte, and acid-base imbalances. Use a drug reference book or a reputable online database to check the potential side effects of other medications. Ask specifically about the use of baking soda as an antacid, which can cause ECV excess because of its high sodium content, that holds water in the extracellular compartment. For an individual who uses laxatives, ask about the consistency and frequency of stools. Multiple loose stools remove fluid and electrolytes from the body, causing numerous imbalances. Patients who are very young or very old, whose I and O of fluid and or electrolytes are not equal, or who have various chronic diseases or trauma are at high risk for fluid, electrolyte, and acid-base imbalances. Surgery causes a physiological stress response, which increases with extensive surgery and blood loss. On the 2nd to 5th post-op days, increased secretion of aldosterone, glucocorticoids, and ADH causes increased ECV, decreased osmolality, and increased potassium excretion. In otherwise healthy patients, these imbalances resolve without difficulty. But patients who have pre-existing illnesses or additional risk factors often need treatment during this time. Increased output through the GI tract is a common and important cause of fluid, electrolyte, and acid-base imbalances that requires careful assessment. Many acute respiratory disorders predispose patients to respiratory acidosis. For example, bacterial pneumonia causes alveoli to fill with exudate that impairs gas exchange. This causes the patient to retain carbon dioxide, which leads to an increased PaCO2 and respiratory acidosis. Burns place patients at high risk for ECV deficit from numerous mechanisms, including plasma to interstitial fluid shift and increased evaporative and exudate output. The greater the body surface burned, the greater is the fluid loss. Hemorrhage from any type of trauma causes ECV deficit from blood loss. Some types of trauma create additional risk. Many chronic diseases create ongoing risk of fluid, electrolyte, and acid-base imbalances. In addition, the treatment regimens for chronic diseases often also cause imbalances. Types of fluid and electrolyte imbalances that occur with cancer depend on the type and progression of the cancer as well as the treatment regimen. Patients who have chronic heart failure have diminished cardiac output, which reduces kidney perfusion and activates the RAAS. The action of the aldosterone on the kidneys causes ECV excess and risk of hypokalemia. Most diuretics used to treat heart failure increase the risk of hypokalemia while reducing ECV excess. Dietary sodium restriction is important with heart failure because sodium holds water in the ECS, making the ECV excess worse. In severe heart failure, restriction of both fluid and sodium is prescribed to decrease the workload of the heart by reducing excess circulating volume. Oliguria occurs when the kidneys have reduced capacity to make urine. Some conditions, such as acute nephritis, cause a sudden onset of oliguria, whereas other problems, such as chronic kidney disease, lead to chronic oliguria. Oliguric renal disease prevents normal excretion of fluid, electrolytes, and metabolic acids, resulting in ECV excess, hyperkalemia, hypermagnesemia, hyperphosphatemia, and metabolic acidosis. The severity of these imbalances is proportionate to the degree of renal failure. Data gathered through a focused physical assessment validate and extend the information collected in the patient history. Daily weights are an important indicator of fluid status. Each kilogram, or 2.2 pounds of weight lost or gained overnight, is equal to 1 liter of fluid retained or lost. These fluid gains or losses indicate changes in the amount of total body fluid, usually ECS, but do not indicate a shift between body compartments. Weigh daily patients with heart failure and those who are at risk for or who actually have ECV excess. Daily weights are also useful for patients with clinical dehydration or other causes or risks for ECV deficit. Weigh the patient at the same time each day with the same scale after a patient voids. Calibrate the scale each day or routinely. The patient needs to wear the same clothes or clothes that weigh the same. If using a bed scale, use the same number of sheets on the scale with each weighing. Compare the weight of each day with that of the previous day to determine fluid gains or losses. Look at the weights over several days to recognize trends. Interpretation of daily weights guides medical therapy and nursing care. Teach patients with heart failure to take and record their daily weights at home and to contact their health provider if their weight increases suddenly by a set amount, and generally the health provider will give you those parameters. Recognizing trends in daily weights taken at home is important. Research shows that patients who are hospitalized for decompensated heart failure often experience steady increases in daily weights during the week before hospitalization. A weight gain of more than 2.2 pounds was associated with increased risk of hospitalization due to heart failure. Measuring and recording all liquid intake and output during a 24-hour period is an important aspect of fluid balance assessment. Compare a patient's 24-hour intake with his or her 24-hour output. The two measures should be approximately equal if the person has normal fluid balance. To interpret situations in which I and O's are substantially different, consider the individual patient. For example, if intake is substantially greater than output, two possibilities exist. The patient may be gaining excessive fluid or may be returning to normal fluid status by replacing fluid lost previously from the body. Similarly, if intake is substantially smaller than output, two possibilities are known. The patient may be losing needed fluid from the body and developing ECV deficit and/or hypernatremia, or may be returning to normal fluid status by increasing excessive fluid gained previously. In most healthcare settings, I&O measurement is a nursing assessment. Some agencies require a healthcare provider's order for I&O. If you want to measure I&O for a patient with compromised fluid status, check your agency policies to determine whether you can institute it or if you need an order. Fluid intake includes all liquids that a person eats: gelatin, ice cream, soups, drinks like water, coffee, juice, or received through an NG tube, a nasogastric tube, or jejunostomy feeding tube. IV fluids, such as continuous infusions or intermittent IV piggybacks, and blood components are also sources of intake. A patient receiving tube feedings often requires numerous liquid medications, and water is used to flush the tube before and after the medications. Over a 24-hour period, these liquids amount to significant intake and are always recorded on the I&O. Ask patients who are alert and oriented to assist with measuring their oral intake, and explain to families why they should not drink or eat from the patient's meal trays or water pitcher. Fluid output includes urine, diarrhea, vomitus, gastric suction, and drainage from post-surgical wounds or other tubes. Record a patient's urinary output after each voiding. Instruct patients who are alert, oriented, and ambulatory to save their urine in a calibrated insert which attaches to the rim of the toilet bowl. Teach patients and families the purpose of I&O measurements. Teach them to notify the nurse or nurse-assisted personnel to empty a container with voided fluid, or show them how to measure and empty the container themselves and report the results appropriately. Accurate I&O facilitates ongoing evaluation of a patient's hydration status. Review the patient's lab test results and compare them with normal ranges to obtain further objective data about fluid, electrolyte, and acid-base balances. Serum electrolyte tests are usually performed routinely on any patient entering a hospital to screen for imbalances and serve as a baseline. These are containers for measuring urine output. Patients need to have good vision and motor skills to perform these measurements. Active involvement of patient and family is an aspect of patient-centered care that is essential for maintaining accurate I&O measurements. When a patient has an indwelling urinary catheter, drainage tube, or suction, record output as the patient's condition requires at the end of every shift or every hour. You can delegate portions of I&O measurement and recording to the NAP with competent skills in measurement. Research shows that visual estimates of fluid volumes are often unreliable. Actual measurement is preferable. In many institutions, NAP record oral intake, but not intake through feeding tubes, IV tubes, which is a nurse responsibility. Similarly, NAP often record urine, diarrhea, and vomitus output, but not drainage through tubes. The responsible registered nurse or licensed practical nurse and the NAP work as a team to record measurements in a designated location in the electronic health record, often on a flow sheet with other information. The EHR program usually calculates 24-hour totals. If an EHR is not used, record INO on paper forms attached to the bedside chart or room door. You or the NAP can calculate 24-hour totals. Possible nursing diagnoses for patients with fluid, electrolyte, and acid-base alterations are shown on the slide. Decreased cardiac output, acute confusion, impaired gas exchange, impaired oral mucous membrane, risk for electrolyte imbalance, ineffective tissue perfusion, impaired skin integrity, deficient fluid volume, excess fluid volume, risk for injury, and deficient knowledge regarding disease management. Think about how you would know if your patient had each of these diagnoses. Remember that we're looking for those defining characteristics. What is it related to, and what is the evidence or defining characteristic that tells us for sure my patient has this? Establish an individual patient plan of care that includes mutually established patient goals for each diagnosis. The patient's clinical condition will determine which diagnoses have the highest priority. If the patient's medical condition is not dealt with in a timely manner, fluid, electrolyte, and acid-base balances will worsen. For example, if a patient experiences vomiting and diarrhea, this needs to be addressed immediately, especially if the patient is young, elderly, or chronically ill. Do not delegate administration of IV fluid and hemodynamic assessment to a nurse-assisted personnel. When the patient is stable, you can delegate daily weights, INO, and direct physical care to the NAP. Collaborative care may involve other services, including discharge planning, nutritional support, and pharmacy. Ongoing communication and consultation are important because the patient's condition can change quickly. Health promotion activities focus primarily on patient education. Teach patients and caregivers to recognize risk factors for developing imbalances and to implement appropriate preventive measures. Patients must understand that infants and children need to replace fluids when vomiting or diarrhea occurs. Adults, especially the elderly and the infirm, also need to replace fluids when increased perspiration occurs. Patients with chronic health alterations often are at risk for developing fluid, electrolyte, and acid-base imbalances. They need to understand their own risk factors and the measures to be taken to avoid imbalances. Teach patients with chronic diseases and their family caregivers in the early signs and symptoms of fluid, electrolyte, and acid-base imbalances for which they are at risk and what to do if these occur. Acute care nurses administer medications and oral and IV fluids to replace fluid and electrolyte deficits or to maintain normal homeostasis. They also assist with restricting intake as part of therapy for excesses. Prevention and treatment of ECV deficit, hypernatremia, and electrolyte deficits are accomplished with enteral or parenteral administration of appropriate fluid. Enteral replacements with oral fluids and electrolytes are indicated for patients who are able to drink. Oral replacements may be contraindicated when the patient is vomiting, has GI tract obstruction, is at risk for obstruction, or has impaired swallowing. A feeding tube is appropriate when the patient's GI tract is healthy, but the patient cannot ingest fluids, such as after oral surgery or with impaired swallowing. Options for administering fluids include gastrostomy or jejunostomy installations or infusions through small bore nasogastric feeding tubes. Patients who have hyponatremia usually require restricted water intake. Patients who have very severe ECV excess sometimes have both sodium and fluid restrictions. It is important to allow patients to choose preferred fluids unless contraindicated. Frequently, patients on fluid restriction can swallow a number of pills with as little as 1 ounce of water. Parenteral replacement includes TPN, or total parenteral nutrition, crystalloids, and colloids, which are blood or blood components. TPN consists of IV administration of complex, highly concentrated solutions containing nutrients and electrolytes, and it's formulated to meet a patient's specific needs. Depending on their osmolality, parenteral nutrition solutions may be administered through a central IV catheter or peripherally. Central venous lines deliver IV fluid into the superior vena cava near the heart. IV devices are called peripheral IVs when the catheter tip lies in a vein in one of the extremities. They are called central venous IVs when the catheter tip lies in the central circulatory system, for example, in the vena cava close to the right atrium. We won't go into great detail on IV therapy because you guys will get that in level 2, but the goal of IV fluid administration is to correct or prevent fluid and electrolyte imbalances. IVs allow direct access to the vascular system, permitting continuous infusion of IVs over a period of time. IV solutions may be isotonic, hypotonic, or hypertonic. We will not discuss vascular access devices any further, again, because you will get that in detail during level 2. In addition to the administration of prescribed medical therapies, nursing interventions may be performed to preserve or restore electrolyte imbalance. Teach patients the reasons for their therapies and the importance of balancing electrolyte I and O to prevent imbalances in the future. Nursing interventions to promote acid-base balance support prescribed medical therapies and aim at reversing the existing acid-base imbalance while providing for patient safety. Patients with acid-base imbalances often require repeated ABG analysis. Determination of a patient's acid-base status requires obtaining a sample of arterial blood for lab testing. An ABG reveals acid-base status and the adequacy of ventilation and oxygenation, and you will learn a great deal more about ABGs and acid-base balance in level 2. After experiencing acute alterations in fluid, electrolyte, and acid-base balance, patients often require ongoing maintenance to prevent a recurrence of health alterations. Older adults require special considerations to prevent complications from developing. Patient and family teaching is important for preventing fluid, electrolyte, and acid-base imbalances and for effective restorative care. IV therapy often continues in the home setting for patients requiring long-term hydration, parenteral nutrition, or long-term medication administration. A home IV therapy nurse works closely with the patient to ensure that a sterile IV system is maintained and that complications can be avoided or recognized promptly. Most patients who have had electrolyte disorders or metabolic acid-base imbalances require ongoing nutritional support. Depending on the type of disorder, fluid or food intake may be encouraged or restricted. Patients or family members who are responsible for meal preparation need to learn to understand the nutritional content of foods and to read the labels of commercially prepared foods. Numerous medications, over-the-counter drugs, and herbal preparations contain components or create potential side effects that can alter fluid and electrolyte balance. Patients with chronic disease who are receiving multiple medications and those with renal disorders are at significant risk for alterations. Once patients return to a restorative care setting, whether in the home, long-term care, or other settings, Drug safety is very important. Patient and family education regarding potential side effects and drug interactions that can alter fluid, electrolyte, or acid-base balance is essential. Review all medications with patients and encourage them to consult their local pharmacist, especially if they wish to try a new over-the-counter drug or herbal preparation. Evaluation of a patient's clinical status is especially important if acute fluid, electrolyte, or acid-base balance exists. A patient's condition can change very quickly, and it is important to recognize impending problems by integrating information about his or her presenting risk factors, clinical status, effects of the present treatment regimen, and potential causative agents. Some possible questions to ask if expected outcomes have not been met are shown on the slide. What difficulties are you having with measuring your I&O daily and keeping a record? What barriers are you experiencing to obtaining the potassium-rich foods you need? Are you continuing to have frequent loose stools or diarrhea? And how do you purchase an antacid, or are you still using baking soda as an antacid?